Hello and welcome. My name is Brian Fairman, and today I'd like to walk you through a poster that I prepared based on research for my PhD dissertation. This poster will be originally presented at the 2014 College on Problems of Drug Dependence in San Juan, Puerto Rico on June 17th. You can download a copy of this poster on my blog at brianjfairman.blogspot.com. For the next few minutes, I'd like to talk about cannabis smoking and the burden of depression in people's daily life. It's been well documented that depression is responsible for a considerable amount of suffering and economic loss. Less well known are the long-term effects a cannabis smoking habit may have on people's mood. Preclinical evidence in animal models suggests the endocannabinoid system is involved in regulating mood, and stimulation of CB1 receptors may have an antidepressive effect. This has led some to ponder whether exogenous cannabinoids, such as those found in cannabis, can be used as an effective treatment for depression. One might then expect the epidemiologic evidence in humans to show that cannabis smokers are less likely to be depressed, except what we find is the opposite. While the evidence is not conclusive, the tendencies of these studies show cannabis smokers have a greater risk of depression, not less. We now need studies to help us better understand whether cannabis smokers might experience more severe depression compared to those who don't smoke cannabis. For this research, I chose to focus on survey respondents' experience of functional impairments they attributed to their depressed mood. Then I estimate whether their level of functional impairment differs by concurrent level of cannabis involvement. Data for this research came from the U.S. National Surveys on Drug Use and Health. I used a nationally representative subsample of about 13,000 respondents who had experienced a sustained spell of depressed mood in the 12 months prior to interview. These depression spell cases were then asked 5 items of a modified Sheehan disability scale to measure functional impairment attributed to depression. Cannabis involvement was measured via 10 items based on DSM-4 criteria for cannabis use disorders. Structural equation modeling in M+ version 7 was used to analyze the relationship between chelate variables and covariates. Looking at the characteristics of the sample of depression spell cases in Table 1, this subsample was overrepresented by females, those younger than age 35, and those who self-identify as non-Hispanic white, as compared to the general population in the U.S. Summary statistics of individual SDS items are shown in Table 2. Based on mean values, depression spell cases had slightly more functional impairment related to relationships and social life as compared to home management and work impairments. The median number of days unable to carry out daily activities was 5 out of the last year, with the highest quartile, the top 25%, had 30 or more days of impairment. Figure 1 displays the final structural equation model and main estimate of interest. The individual cannabis problem items, represented by boxes, can be thought of as observed manifestations of an underlying latent trait of cannabis problems, represented by an ellipse with causal directional arrows pointing towards each CP item. Similarly, functional impairment attributed to depression is another latent trait that determines responses to the 5 SDS items. Under the causal assumption of the model that cannabis problems influences functional impairment, we find a positive association shown by a beta coefficient of 0.2 and 95% confidence intervals that do not trap the null value of 0. Thus, higher levels of cannabis problems are associated with higher levels of functional impairment attributed to depression, controlling for the additional influences of sex, age, ethnic self-identification, tobacco dependence, and alcohol problems. Since an earlier onset of depression than cannabis smoking would violate our model's causal assumption, we re-estimated the model without these exposed cases and discovered no substantial difference in our estimates. From these results, we conclude that cannabis smoking in the form of problematic use may increase functional impairments attributed to depression, and thus exacerbate depression severity rather than alleviate it. We note this finding may be important to clinicians with depressed patients who currently smoke cannabis or may be considering medical marijuana as a treatment. Further research into the role of the endocannabinoid system as a therapeutic target for depression is warranted, but our research calls into question the effectiveness of using exogenous cannabinoids for this purpose. Though we excluded respondents whose depression preceded cannabis onset, we cannot rule out the alternative interpretation that depression cases with higher levels of functional impairment might turn to smoking cannabis to alleviate their symptoms, even if it proves to be ineffective. Our study may be limited by the fact that cannabis withdrawal was not measured, and thus not evaluated in our models. However, since withdrawal is likely to be associated with increased depressed mood, we might be underestimating the true relationship under study. We also cannot rule out other causes of functional impairment other than depressed mood that could be occurring in the life of the respondent. Despite these limitations, our study benefits from a number of strengths that promote more precise estimates and better generalizability to the wider U.S. population. Lastly, our focus on depression severity and use of advanced statistical methods in this study advances research on what has previously been done on the topic of cannabis smoking and depression, and where prior relevant studies have used only treatment-seeking or college-aged samples. I would like to thank my co-author on this poster, Jim Anthony, as well as the MSU T32 Drug Epidemiology Fellows for their assistance in the production of this poster. I would like to acknowledge the National Institutes of Health and the National Institute on Drug Abuse for their funding support. The content of this poster is the sole responsibility of the authors and does not necessarily represent the official views of Michigan State University, the NIH, or NIDA. The authors declare no conflict of interest with respect to this research. Thank you, and enjoy the conference.